And I now have the honor to introduce Veronica Duell, who is the Public Relations Manager of the Student Network Organization, who will be introducing our keynote speaker. Thank you. Good afternoon, everyone. I hope everyone had a nice lunch and is ready to listen to our next keynote speech on the theme of interprofessional education and practice. We are honored to have Jusie Lydia Siega Sur, former Dean of the University of Philippines Manila School of Health Sciences, as our speaker. It is my pleasure to introduce her to you. She's a member of the International Reference Group on Global Consensus on Social Accountability in Medical Education and the United Nations Population Fund Technical Consultant for the Ministry of Health in Timor-Leste. She also participated in developing a framework for evaluation of social accountability in medical education with training for Health Equity Network. She received her Bachelor of Science degree in Nursing, magna cum laude, from Similian University College of Nursing in 1979, and a Master's of Health Professions Education in 1989 from the National Teacher Training Center for the Health Professions at the University of the Philippines, Manila. Since 1987, Professor Siega Sur has completed numerous fellowships, including those with WHO, JICA, and UNFPA, and most recently with Duke University and the National University of Singapore on team-based learning. Currently, she's working on a doctorate in management of human resource management in the Philippines. Now I am pleased to introduce her to you as our next keynote speaker.
Thank you, Veronica. Good afternoon, everyone. First of all, I would like to acknowledge the Larrakia people as the traditional owners of the Darwin region. We pay our respects to the Larrakia elders, past and present. So first of all, let me ask, how many in this room have been implementing IPE? Can we have a show of hands? It's not 50%. You know, kidding aside. No, just kidding. I was hoping that there would be more who would raise their hands and say that, yes, we're doing IPE, because then I would have been done with my keynote. Anyway, I know that each one of us in this room may have our own stories to tell. Did I click it already? To tell about IPE, which you can share in your small discussions in the next 4 days that we are here in the conference. But it is my hope that when we go home by the end of the week, one of the key messages we will take home with us is that interprofessional collaboration in both education and practice is the way to go if we are to make greater impact in achieving better health outcomes. So, while IPE, we've heard IPE has been talked a lot about, but not many have embraced it. Neither are there any investments, or there's very little investment in IPE, be it in teaching, in service, or in research. So I would like to begin my presentation with a short video. This was produced by the College of Medicine in the University of the Philippines. And we also used it with the Zwillig Family Foundation in the leadership of training of our local chief executives and health leaders. In school at where I work, we also use this to teach our students on concepts of urban primary health care, systems thinking, stakeholder analysis, discussions on the 6 building blocks for health, as well as the social determinants for health. So let me first show this film.
The village of Tanyong lies in the curve of the Malabon-Navotas River. On a total land area of 5 hectares lives a population of 12,400 individuals, or 1,850 families. To reach the riverside houses of Tanyong, one has to cross unsteady makeshift wooden bridges. It is not uncommon to hear of children falling into the murky black waters of the river. A survey revealed that only 10% of the households have toilets. The remaining 90% use the river to dispose of human wastes. Only 10% avail of water piped into their houses. 90% buy water from entrepreneurs who fetch water from only 2 deep wells in the village. 5 gallons of water cost between 15 and 30 pesos, depending on the distance of the consumer's dwelling from either well. No one living in Tanyong owns their home or the land they live on. Rent is 500 to 1,000 pesos a month for a small room, and the bigger room costs up to 1,500 to 2,000 pesos per month. Jaime and his family live in the village of Tanyong. He was among the 70% of the population who migrated to Metro Manila from the provinces looking for a better life. A former peasant farmer, he now earns 165 pesos a day working hard labor at a construction site in Quezon City. Jaime and his wife Lucy can afford only 50 pesos a day to feed themselves and their 4 children. Jocelyn, 5 years old. Marites, 4 years old. Antonio, 2.5 years old. And Rosario, a year and 4 months old. Lucy tries her best to provide 3 meals a day, often skipping meals herself to feed her children. Instead of a good life, Jaime and Lucy found themselves chronically in debt. Lucy graduated from high school, unlike Jaime, who completed only 3 years of elementary education. Neither of them learned the proper ways of caring for children. When the eldest child was still a baby, Lucy was told by a physician not to breastfeed her child. She was told to buy an infant formula instead. All the children were raised on condensed milk because this was cheaper than formula milk. Lucy had no idea of proper nutrition for her children. As a result, all the children were malnourished. They were sickly, prone to respiratory tract infections, and frequently had fever and diarrhea. They frequently passed worms with their feces. Lucy thought this was a good sign. She believed that worms aided in the digestion of food. The 2 youngest children, Antonio and Rosario, did not receive vaccinations. The barangay health center no longer had free vaccines for all the children in the village. Rosario, the youngest, was the sickliest among their children. She was very thin, pale, and invariably suffered from diarrhea. One day, Rosario contracted measles. Lucy brought Rosario to the nearest public health center where consultation was free. The nurse in the center, however, told Lucy that the center had finished the year's budget allotment for free medicines. The barangay health center's request for a larger budget for more medicines had been turned down by the city council. This was because the council suspected misuse of funds by the municipal health officer and by the mayor. Lucy decided to buy a bottle each of the medicines prescribed for Rosario. Carbocysteine for the cough at 109 pesos a bottle, a diarrhea medicine at 243 pesos a bottle, and an antibiotic at 150 pesos a bottle. After she finished the medicine, Rosario was still very ill. But the couple could no longer afford to buy more medicines for their child. Rosario's condition grew worse. Jaime and Lucy brought Rosario back to the health center. but were advised to bring her to a private hospital. After only one night, their bills piled up to 4,125 pesos. The couple decided to take Rosario home against the doctor's advice. Jaime and Lucy were told to bring Rosario back to the hospital once they had enough money to pay for services. After 1 week of continuous fever and diarrhea, Rosario continued to suffer dehydration. She became severely weakened and eventually died. Why did Rosario die?
Why did Rosario die? For us as health professionals with a largely biomedical orientation, it would be probably easy for us to identify and say Rosario died of dehydration due to diarrhea, she died of measles, and all other comorbid conditions. But if we look deeply into the story, there are more stories behind Rosario's death. Some are related to weak health systems, poor governance that was ridden by corruption, the lack of financing, poor access to medicine, inadequate health human resource, both in quality and quantity, and poor service delivery. Education, housing, water, sanitation, and poverty were also among the factors that all contributed to Rosario's death. So why did she die? This slide shows the work of my students. This is the output of my students when they tried to analyze why Rosario died. The systems affected and the stakeholders that they would need to engage in order to prevent more Rosarios from dying. That is why you have several meta cards there, because the first meta card was supposed to identify what building block needed to be strengthened or was affected. The second meta card was supposed to identify who are the stakeholders that they're supposed to engage. The first, the blue one, by the way, were the causes. And then they had the yellow one, which was the 6 building blocks or systems that were affected. And then the green ones were the stakeholders that they would have to engage in order to prevent more Rosarios from dying. You know, when my students started to make their presentations, they were so confused because of all the arrows. The drawing in itself was so complex with all the arrows showing the relationships. They just didn't seem to know where to start. The story of Rosario brings to the fore the complexity of our health and social challenges and how intertwined all these are. They just cannot be addressed by a single profession or sector. While intravenous fluids, good health services, medicines, if they were available, would have allowed Rosario to survive. But even if she did, returning Rosario to the sick system where she came from will only repeat the cycle. So what good does it do to treat a person's illness if only to send them back to the community that made them sick? As health practitioners, we were taught simple water treatment at home, but we were not taught how to build water systems that could supply safe water to communities. We do health education, but would that be enough to overhaul the entire educational system that failed to educate our mothers? Can we provide livelihood to address poverty that has prevented them from finishing school and finding employment to provide for their family's needs? There are too many related factors and social determinants that must be addressed. There are too many stakeholders that must be engaged. Should we let more Rosarios die because we have been learning and practicing in silos? I guess the answer would be definitely we cannot do it alone. But yes, we can talk and communicate and dialogue with each other, with other professions and stakeholders. We can learn about and from each other and work towards achieving better health outcomes, which is in essence interprofessional education. Today, I would like to share with you some of the experience we have gone through in the Philippines in both health profession and education and practice that has gone beyond collaboration among ourselves as health professionals. When the training for health equity began in 2008, way back 2008 in Cuba, I was then Dean of the School of Health Sciences, which was one of the founding schools of the NET. Where are we located? We're located in Leyte. If you remember, this is Central Philippines. If you remember, this was the region that was hardest hit by Typhoon Haiyan in 2013. Everyone in the group was a doctor. As I was introduced, I am a nurse. Everyone in the group was a doctor except me and Björg, who was a journalist. But we all share the same passion for social accountability and health equity. But in the process of the discussion, I felt everything was so doctor and medical education focused. Nobody was talking about the entire health workforce. Right from the beginning of that very first NET meeting, I've always spoken out and questioned, with apologies to the physicians, why so much focus was placed on the physicians and medical education. Achieving health is a responsibility of a whole health workforce, and not only that, but the communities themselves who are affected by the problem. They also need to be empowered and to participate in their own health care. With the social determinants of health, the non-health sectors also need to be engaged. At that time, I tried to understand where they were coming from, but I guess not only for medicine, but all the other health profession, it's something that is historical. We all have been learning in silos. There has been so much exclusivity in the way health professions education has been conducted. Our health education hardly prepared us to function as members of professional teams in the future. When the NET started, we were focused on our social accountability mandate. I remember the WHO document that was published by the WHO and written by Dr. Charles Bolen. But at that time, we were so focused on that, we didn't even realize that we were already an interprofessional group working together when we developed that evaluation framework. So it started as a framework for evaluating social accountability in medical education. But the NET has moved on and embraced the other health professions. So now we don't call it SAME, which we called it initially. We now call it SAPE, or Socially Accountable Health Professions Education, recognizing that health is a responsibility of a health workforce. I also got to be part of the conference. I was lucky also to be part of the international reference group that contributed to the development of the global consensus for social accountability in medical education. We went through a 3-month Delphi survey, and then after that we culminated in Gonobi, South Africa. Most of the people there were doctors. I don't know if there was another nurse in the room. Probably I was the only one, but I knew there were a lot of pharmacists, and I wondered when they invited me to become part of the group, since it was supposed to be a global consensus for medical education, social accountability in medical education, if they remember that I was a nurse. But if they did, and they still asked me to join in, then that was somehow a recognition of interprofessional education. Perhaps I wore a different set of lenses. When people were not yet talking about social accountability, I think the document of Dr. Boland was published only in 1995. But our school was established 43 years ago in 1976. Alma Ata was in 1978. And we were already doing socially accountable health professions education without the term social accountability. That term was not yet coined at that time. All we wanted to do was we wanted to produce health workers for the Philippines who would stay and serve. Because most of our medical and nursing graduates were leaving the country, like 63% of the premier university of the Philippines was sending their graduates abroad. We were considered the #1 exporter of nurses and the #2 exporter of physicians. So the school that we have, is said here, we train health workers to stay and serve in the Philippines and not to grow abroad. We implement an innovative community-based, community-oriented, competency-based curriculum, step ladder curriculum. It's a career ladder. It was before that, it was jointly established by the University of the Philippines, the Department of Health, the Department of Interior and Local Government, some NGOs, and the communities. So our school from the very beginning has been an example of the academe, the health sector, the local government sector, partnering and collaborating to achieve better health outcomes and quality of life in the Philippines. It was established initially by these 3 organizations. We later set up 3 campuses. Our original campus was in Central Philippines, which was hit by Typhoon Haiyan. Then during my term, we established 2 more extension campuses in the north and in the south. So as dean of the school, at that time, I had to supervise 3 campuses that were geographically distant from each other. I remember our chancellor would ask me, my nickname is Chichi, so he would say, "Chichi, what do you want? Do you need a chopper?" So later on, in the establishment of our 2 extension campuses, this time we partnered with the local government units. This time it was the local government units that provided the property and the infrastructure, plus scholarships for the students that they were going to develop into health workers to serve their regions. And then we also recruit practitioners as well as the staff of the Ministry of Health to serve as preceptors. This served to bridge the gap between education and practice. So where do our students come from? Our recruitment program is also unique. It's a way of empowering people and communities. So all our students are recruited and nominated by and from depressed and underserved areas in the Philippines, including indigenous peoples from the north and the south that are in need of health workers. There are no walk-in students. We don't have a student who comes in and says, "I want to study here. Let me take an exam, and if I pass, I'll study here." Each student is attached to a community that nominated them. The community is actively involved from the time the student is recruited, during training, up to deployment and utilization. So after completion of whatever level they complete, the student is expected to go back and serve in these areas. We do not expect to see them working in urban centers where health facilities and health workers are concentrated. So everyone begins. This is our curriculum. It's a step ladder curriculum where all students, as you said, are recruited from the community. They may be indigenous people. They come from largely low socioeconomic status. And everyone begins at the level of the midwife. Based on need, they can progress to become nurses and ultimately physicians. In between program levels, between nursing, medicine, and midwifery, there's a period which we call service leave. And the students literally leave school and they go back to their communities to serve with the competencies of whatever level they have completed. Most of their training takes place in the community where they interact with various levels of students, other sectors, and the community. So one community can actually have all students from midwifery, nursing, up to medicine at a given time. What's beautiful about this is that a student who completes the medical program or becomes a doctor is like a health workforce rolled into one. She is a doctor, a nurse, and a midwife. A nurse, one who completes nursing, is a nurse at the same time a midwife. And a midwife is one who has had the opportunity of interacting and learning with nursing and medical students during their training. I remember in one of the meetings of the NET, which took place sometime in 2011. And so members of the NET came to the School of Health Sciences. And during one of our community visits to the rural health station, I think it was Dr. A.J. Nusi who asked the question. He asked the question. He was wondering because the student that was at the station was a first-year medical student. And so he was wondering what a first-year medical student could do at the health center. So he asked, what would happen if a mother who is about to deliver, comes to your clinic in the middle of the night? What would you do? She answered calmly, it would not be a problem because I am also a midwife. Our students were not the best and the brightest from the communities. We have a philosophy of universal education. So when they come in, unlike other schools who recruit the cream of the crop, we don't recruit, we don't base your admission on your high school academic performance, neither do we give an academic exam or an admission test to our students. Coming from the community and a willingness to return and serve were the most important factors in deciding whether a student was going to be admitted or not. As I said, they came from largely low socioeconomic status, and we also had students coming from indigenous peoples of the Philippines. Today, our graduates have an overall combined retention rate of 85% who are still serving in the Philippines. And more than 90% of our physicians are still serving in the communities, some serving there for already more than 20 years. Because of our innovative program and our high retention rates, the Philippine government actually recognized the school in 2008 with what is known as the Presidential Lingkod Bayan Award. Lingkod means to serve. So it's actually the highest award for service to the nation which is given. And our school received that award in 2008. So we have midwives, nurses, and doctors in underserved areas of the country. I see our graduates serving all over the Philippines in areas of greatest need as midwives, nurses, doctors. Some are community organizers, some are sanitary inspectors, some are school nurses. We realized, or population officers, we realized that they can perform these different functions. Some have even risen to the level of chief of hospital of district and provincial hospitals. They're not working in the big urban cities. We also had 2 people who were consultants of the WHO. Like, I don't know if some of you know Dr. Sumana Barua. He was the global team leader for leprosy in Sharo. First, he was with the Western Pacific, and then he became global team leader for leprosy in Sharo. And when I talked to him, he's Bangladesh, he's from Bangladesh, he said, "Mom, the lessons I learned at SHS, I have been able to apply in other countries that are similarly situated as the Philippines." He was my student before, and I saw his struggle. But when he became he took his doctorate in Tokyo International University, and he said to me, "Mom, when I was your student, you gave me an NT grade." You know what an NT grade is? Needs tutorial. We don't give numerical grades to our students. We just give them qualitative grades of passed and needs tutorial. And if we give them a grade of needs tutorial, what would that mean for us faculty members? We would have to do tutorial sessions until they learn the desired competencies we wanted them to develop. Why did we do that? We didn't want them to compete for grades as in traditional schools. We wanted them to focus on learning the competencies that they needed to serve in depressed and underserved areas of the country. So he kidded me, "Mom, I remember before you gave me an NT." And then he showed me his transcript in Tokyo, which was all 1.0. And he said, "In fact, Mom, I did some of the lectures." So that somehow made me proud. It was when I see my graduates now, it's very heartening to hear them say that after leaving school, the training they had in SHS had helped them become what they are today. They would say, "Mom, if you did not train us that way, we couldn't do what we do today." Doing multi-sectoral collaboration to bring about better health. From practically day one in the community, very young students, 16 years old, they had to learn how to communicate among themselves, with the community, with other sectors, as well as the politicians. They had to give up their shyness because they had to coordinate with various levels. So that is what our school is about, in brief. But I would also like to share with you another experience that we have had, this time in interprofessional education and collaboration in practice. This was a program we engaged with the Department of Health, the Swilig Foundation, as well as the municipalities who enrolled in the program. It was a program that was designed to train local chief executives and local health leaders in health leadership and governance. We have been working with the Department of Health since 2013 because we were identified as the academic partner to roll out the training for the leadership training for the mayors as well as local health leaders. It was felt that at the end of the day, what makes the 6 building blocks for health turn is leadership. And the key to that is the mayor and the local executives. And therefore, they needed to be trained. The program aimed to create immediate impact on achieving the Philippine Health Agenda and Health Sustainable Development Goals by improving local health system in the priority provinces, cities, and municipalities through improved leadership and governance on health. It has 3 components. The first is leadership development. The second is strengthening the health systems. And the third, community empowerment. The mayors or local chief executives, together with their municipal health officer, had to go through a training which lasted for 18 months. There were 3 modules with 6 months of practicum in between in their respective municipalities. Coaching and mentoring were done by staff of the Department of Health, whom we call as development management officers. So going back to their communities after the training, they were guided with what we call a primary health care road map, which was based on the 6 building blocks for health of the WHO. So they had the task of strengthening their health systems through multi-sectoral collaboration and empowerment of communities. An important component of the training was the application of what is known as the Bridging Leadership Framework as a leadership approach to health system strengthening and increasing the community voice in addressing health and social challenges. Why the Bridging Leadership Framework? It is because our health challenges and social challenges are so complex. They cannot be addressed by only one sector. They're so complex. We have all the social determinants of health. They cannot be addressed by only one sector. And so therefore, it's beyond the capacity, as we said, of one sector to address it. And so we had to bring in, it needed the efforts, combined efforts of the private sector, the public sector, as well as the community to come up with resolutions, shared resolutions to resolve their problem. That is why we use the Bridging Leadership Framework as a platform or the approach for achieving better health outcomes in the municipalities. So it has 3 phases. Okay. The BL framework, for short, is an approach applied especially in addressing complex issues that cannot be addressed by one sector alone. It consists of 3 phases. So the first phase in the diagram is what is known as the ownership phase. Then the second phase is co-ownership, and the third phase is co-creation. A bridging leader must first and foremost own the issue. A BL does not see the issue as a separate entity to solve. Rather, he sees himself or herself as part of the issue, and that he or she must directly contribute to the issue. The leader has that level of self-awareness and purpose that drives him to own the issue. To own the issue requires also for the BL to understand the situation through systemic analysis, formulating a vision of his own preferred reality, identifying potential stakeholders that can help him address the issue, and eventually make a personal response to the issue or challenge. In the second phase of co-ownership, the bridging leader convenes the stakeholders of the issue. Through a process of dialogue and engagement, the stakeholders are supposed to arrive at a shared vision and shared response, with the vision becoming the societal outcome aspired for by everyone. In practicing ownership, the leader is expected to lead change, which is the ability to generate genuine enthusiasm and momentum for organizational change. It involves building a shared sense of commitment to a common goal and utilizing interventions to help close the gaps or improve competence of staff to achieve that goal. Furthermore, it means engaging and enabling groups to understand, accept, and commit to the change agenda. Lead his multiple stakeholders, build and maintain high trust, develop synergistic working relationships across relevant sectors necessary to implement the change agenda, and also coach and mentor others for this. His is the responsibility of creating an enabling environment that will nurture and sustain a performance-based coaching culture. Lastly, the co-creation process involves a bridging leader being able to make new institutional arrangements among the stakeholders to address the issue. These new institutional arrangements, which are inclusive, not exclusive, accountable and transparent, lead to more empowered citizens and more responsive institutions that come up with more responsive out-of-the-box solutions. Empowered citizens and responsive institutions supported by new arrangements collaborate on responsive programs and services that bring about equitable health systems. The leader needs to champion and sustain social innovations that lessen social inequities. He should have the ability to challenge, to champion, and sustain conventional practices and approaches, generate new ideas and fresh perspectives, create creative solutions and strategies aligned with goals and directions that lessen social inequities. In summary, the bridging leadership process, after having understood the situation, the bridging leader makes a personal response. Acknowledging that he cannot resolve the complex challenge on their own, they engage stakeholders, including the community, to share the change vision and produce a collaborative response to the challenge. It is through this collaborative response, new institutional arrangements are created and outcomes are produced that are sustainable by continuous societal responses. When we started the program with the mayors in 2013, we had mayors who thought that the health sector was an independent republic and that they had no concern over the health in their municipalities. There were even mayors and municipal health officers for political reasons who were not talking with each other. We met mayors who didn't know what is FIC, for a fully immunized child. They didn't even know that there were supposed to be health targets to be achieved. The roadmaps that we gave them, initially the baseline data showed that they were mostly red because the different indicators in the roadmap were coded, color-coded. So if they met the standard, it was colored green. If they met more than 50% or 80% and above, it was supposed to be colored yellow. And if they fell below the target, then it was colored red. I will never forget one sad story I heard about a municipal health officer. We do what we call a final selection workshop as to which municipalities are going to be part of the training. And so there was this mayor who was asked how he felt about the malnutrition problem in his community, which was colored red in the roadmap. He couldn't answer because, as I said, the mayors before didn't care about health. So he passed it on to his municipal health officer. And that was a very disappointing and sad answer for me because the municipal health officer replied, "That is not my concern. That is the concern of the Department of Social Services and Development." Why? Because the budget for the feeding program is not lodged with the Rural Health Unit. It's lodged with the Department of Social Welfare and Development. Somehow I said, he's been in the service for 20 years, but he could not see the interrelationships, that malnutrition was not simply addressed by feeding programs. A mayor refused to allocate a budget for health in communities that were branded as his political opponents. He said, "Ma'am, my roadmap will never become green because they are not my allies." He said, "But if they voted for me, I would be willing to put in a budget for health, even using my own money." At the completion, he did not really but what happened to that mayor at the completion of the program? He was one of the mayors we saw transformed, and from a budget of 8%, because the standard we required a health budget of at least 15% of their internal revenue. His budget increased from 8% to 22%. And you know what he said? "Ma'am, I realized if I still the politician in him, if I address the health needs of my community, I can convert them to votes. So it's still politics, but he changed his mind. He was able to increase the budget. So after the completion of the program, we saw health leaders, local chief executive, and health systems transformed. There was 0 maternal death. We also teach the same framework to our students. When I got involved in this, it was just something accidental. And so myself and another colleague, he's here, Dr. Labarda, we attended the training. We were not actually exactly participants. We were observers. And I said, I fell in love with the concept of bridging leadership. And so I said, why should I wait for my graduates to become practitioners before they learn bridging leadership? Which is one good way of doing IPE. So we talked with the Zwillig Family Foundation, who was then implementing that program. That was in 2011. It was not yet implemented by the DOH. And we invited them to Leyte, to the School of Health Sciences. We trained all our faculty. We gave up our classes for a week. We trained all the faculty. It was not only that. We invited participants from the Department of Health. We've invited participants from the social welfare, from the provincial health offices, and our PhilHealth, which is the National Insurance Program of the Philippines. I realized that health professions education can benefit from using the same framework. In the ownership phase, students can be made to take a deep look into the values they and their professions profess, critically analyze the health inequities and their role in its resolution, and identify the stakeholders they need to engage. In the co-ownership phase, students can be made to convene the stakeholders that they need to engage. They're taught dialogue skills, different types of dialogue skills. Through dialogue, they come up with a shared vision for the health challenges faced by the community where we field them during their training. And then in the co-creation phase, skills on creativity and innovation can be developed as they engage stakeholders in coming up with out-of-the-box solutions to old issues that have not been resolved by implementing the same solutions year after year as they went about their community experiences. In my talk with students and graduates and practitioners, and even in the literature, the application of IPE has helped them develop both group and community skills and made them aware of the competencies of opportunities, other professions, and what the opportunity of working with them can bring. It helped them understand the importance of teamwork and communication. With shared responsibility, they realized that the burden was lightened. It helped them to see the big picture and encouraged innovation. It developed attitudes of inclusivity rather than exclusivity in addressing health challenges and issues. It transformed individual lives and communities. We saw leadership transformation among the mayors and rural health officers, and transformation of their primary healthcare roadmap. This is an example of a primary healthcare roadmap that looks like a Christmas tree when they started the program, into something like this when they completed the program. From red, yellow, green, majority of the blocks were now green and there was no red indicator. And it was a must because we believe this was supposed to be a leadership transformation program. It was a must. The first block there is leadership and governance. It was a must that for them to graduate from the program, there should be no red indicator in the leadership and governance block. From our students, it was very heartwarming. I would like to share with you what some of our students says. They said, we went to the people, lived with them, that enabled us to understand their poverty. Oops. What was pleasurable was how they would change their ways. We realized they too had their dreams. All they needed was to be motivated and engaged. We taught them through interdisciplinary teams, we taught them group processes. From another student, Transforming Lives, he came from a family of 10 siblings, and so he said, when I was in grade 6, my parents separated. For 3 years after high school, I plowed the fields, sold firewood and bananas. My neighbors would tell me, wala kang pag-asa. In other words, you don't have hope. You might as well get married. But after completing the program, he says, SHS taught him perseverance, commitment, and compassion. He sold sandals and shoes to the faculty as a student just to survive. I remember I bought 2 pairs of shoes and a belt for him. And he would cook for his classmates so he would get free meals. Today, he is one of the 2 physicians, 2 anesthesiologists in the island of Biliran in Region 8. But what heartens me so much is when he says, my work is not done in serving the people. Without SHS, I would not have become a doctor. And there was one funny story about him because he was also my student when he was still a nursing student in the community. And when he became a doctor already, he told me, Mom, when you made me teach the community about environmental sanitation, at the back of my mind, I remembered our house did not have a toilet. So now he's a doctor, he's an anesthesiologist, he now has money. One of the things he did was he donated a parcel of land to the community that nominated him for their health center. But the funny story was about the toilet because he said, Mom, I didn't have a toilet in my house before, but now my house has 6 toilets. He has a toilet for every room, he has a toilet in the kitchen, and he has a toilet for visitors. That really stuck to him. And then the last one is on transforming communities. This happened, our region is known for, subversion, and we have what we know, the New People's Army. So we have a graduate who's been there for, I think, almost 20 years. And this is a community which can be reached by, most villages can be reached by horseback or by walking. So one afternoon, it was 3:00 p.m., Dr. De La Cruz was caught together with the rural health staff in the crossfire. Her midwives, she has midwives who are also our graduates. It's a very remote municipality. They were caught in the crossfire just 15 meters away from the rural health center, between the military as well as the government sector, the military and the New People's Army. And so what they did, they hid under the tables in the RHU. There were bullets crossing over their heads. Anyway, what happened was, undaunted by those encounters, she's not from there, she's from another municipality which is closer to the center of the region. But despite that, she went back to the same municipality, and until today, she continues to serve there. I asked her, I meet her several times, she said, I asked her, are you ready to leave? Not yet, Ma'am. My work is not yet done. And so now she has, from the same municipality, they nominated another scholar who's in our school taking up midwifery. Hopefully, they wish she would graduate medicine, so she would go back and serve and take her place. So when she first worked in that community, only 26% of the children eligible for immunization were immunized. But now the figure has tripled 3 times. Another transformation of communities was also by another doctor from the north. What happened was he worked as an MHO after. And he said, my work in the community was not difficult because this is how SHS trained me. This is what they trained me for. So they formulated policies on health insurance, they improved their health facilities, they took away the kits from the traditional birth attendants. In the Philippines, traditional birth attendants are no longer allowed to handle deliveries, and deliveries should be done in health facilities by a skilled professional worker. When he also entered, there was only 20% facility-based delivery. And when he left, it had risen to 93%. He left as municipal health officer. He went to school, and he eventually succeeded me as Dean of the School of Health Sciences. So we see our own graduate becoming Dean of the School of Health Sciences. He finished his term. Now he has gone back to the region where he comes from, where he's doing family medicine. The world over, interprofessional education has been endorsed by various associations as a mechanism to improve quality care and improve health outcomes. But to be effective, it must be introduced early on in the curriculum and continuing into practice to best prepare our graduates, our future health workers, to work for professional teams. There will be challenges and barriers, ranging from turfing between professions. Luckily, we don't have that at the School of Health Sciences. As I said, I am a nurse. I became a dean of a school that runs a medical program, a nursing program, and a midwifery program. We only have one dean, but we have chairs for the medical department, for the nursing department, as well as the midwifery department. There will also be leadership buy-in may also be a problem, administrative concerns, logistics, scheduling of activities, increased faculty load, and even engaging community partners. In closing, I would just like to say, the struggle has been real, the struggle is real, and will be real for those who would venture into this. But I say that it can be done. Thank you and good afternoon.
Wow, thank you, Professor Siega Sur, for sharing your experience in interprofessional education and practice. It was really a very thought-provoking and inspiring presentation, and I was really moved by how much you care about your students, and especially the last bit where you really wanted to show how students feel about this kind of education. And I really, as I'm starting internships, I will definitely be looking for ways my university engages with other health professions and local communities, as your program is really an example that I hope other universities can follow. I would like to now open the floor for questions from the audience. We have about 10 minutes.
Thank you so much for your presentation. It really was inspiring. I don't know if people can hear me. Yes, okay. I had a very simple, I guess, question, maybe if you could answer. If a student wants to go through the whole process, usually how long does it take them? So if they want to go from being a midwife all the way to becoming a physician, how long? Because you mentioned they have to live in the communities and serve. So what's the expectation in time they serve, and how can they transition to the next step and then to the third step? Thank you.
Okay, thank you for that question. What we do is also something innovative. The whole program, if you go from midwifery, nursing, and then medicine, the least time you would spend in school and going back to the community is not less than 10 years. And each student is required to render what we call, when they enter the school, they have what we call a return service agreement with the university. to return and serve the community for a period of 2 years for a year of study. But that's the minimum, but not everybody progresses at the same time. There are 3 factors that must be considered, and the primary factor is community need. If you were trained as a midwife, you may personally want to become a nurse, but the community who nominated you may say that we need a midwife now. And so they will not endorse you because you have to be endorsed by the community that sent you. And so if you are not re-endorsed by the community, you cannot progress. If they say we need your services, then you will have to stay. We have several students who have been in that situation already before. Like she finished nursing, and then she went back to her community. Her community needed a midwife. The position available was a midwife, but she was a nurse. But since this was a call to service from her community, she took up the position of midwife, and she served there for 13 years before she came back to the school to proceed to the medical program. So she eventually completed the medical program, and where is she now? She's back in the home province, in the provincial hospital of the province that sent her to the School of Health Sciences. So not all students may progress at the same time. There may be other reasons, like some need to support their families, because it has also been a means for alleviating poverty. Some got married along the way, so they don't progress at the same time. So the primary criteria for moving up to the next level is community need. And of course, as we said, the student must say yes, because they might decide that, Mom, I'm going to serve first. I will go up to the next level later on. We've had several students who have done that. And then the third, of course, is assessment of the faculty. So there must be 3 yeses. The community must say yes, the student must say yes, and lastly, which is a smaller portion in terms of weight, the faculty must say yes. And we also look into health manpower complement in the areas where they come from. We look at access to health services as part of the criteria when we assess students and determine whether they should progress to the next level or not. Were there other questions, or did I answer your question? Okay. Yes.
Thank you very much. A question on the Bridging Leadership program. What specifically was happening to bring the red benchmarks into green? I mean, what was happening with those mayors and anyone else that was in the course that brought them to delivering that process?
It was, as you said, it's not really the numbers or the colors that matter, but the stories behind those colors that mattered. They went through a program wherein they had to go through ownership, co-ownership, and co-creation. So in the beginning, they were made to reflect on their leadership lifeline and also reflect on the communities, the challenges of their community. So they went through a series of reflection. We gave them skills in how to analyze their health challenges so that they could think strategically on their health issues and at the same time do problem solving and decision making. So they had this. And then I think a very important thing was they had to go back to the communities after each module where they were tasked with strengthening their health systems. So they had to work with the other sectors. Under the Philippine Local Government Code, we had, there is what we call a local health board at the municipal level. And they had to activate if it was already organized, or organized local health boards. And it was through these local health boards that they worked in achieving the health outcomes. So they bridged, they shared their vision, and then they engaged the other sectors so that they could come up with a shared vision, and eventually they work together co-creating new solutions. The course is not actually, it's a practitioner course, but it's not like the course that we have. It's not an academic course. It's a practitioner course, and it's what we call a transformational course that was designed to transform individuals as well as health systems. If you would actually like to know more about it, one of the faculty that has joined us here is Dr. Meredith Labarda. She was chair of the medical program when I was dean, and both of us are the active faculty members who are working on this program. When I was dean, she was the coordinator for the program, and then after that, she left for study leave, and I was no longer dean. I became the coordinator of the program. And on Friday, I think her poster presentation is about that program that we have been implementing. So I think you can learn more about it from the poster that she will be presenting on Friday afternoon. Morning, I think it's at 10:30. So if you're interested more about the Bridging Leadership Program, she did a research on it as part of her dissertation, and she will be sharing it with you during the poster presentation on Friday. Because it will be because one thing she really went down to the ground level after the program had been conducted. She conducted interviews with key informants, with the communities, as well as those who underwent the program. And so she took it verbatim, she got stories from them, and these were the stories that made the transformation in the roadmap possible.
Okay, thank you very much. I'm Titi Safitri from Gajah Mada Medical School, Indonesia. I'm very touched and impressed and speechless with your story. And my first question is, so under your regulatory framework, it is possible for the students to stop for a while and then continue to study without age limitation? Because some age limitation. I mean, sometimes you have to. Age.
Oh, okay.
Yeah.
Age limitation.
Yeah.
Yes.
For example, because in my country you want to enroll as a medical doctor student, you have to have a certain limit of age. And secondly, how do you keep this program sustained? Okay. Yeah, and then the third is, in fact, what I have been dreaming for decades about how a university should be has been implemented in your case. And I'm now a bit worried about what happens in my country, where our government is so obsessed with university ranking, international university ranking. So all universities have to be internationally standard. So we hope that this opportunity for health can spread the word to the governments to look into their community and how to transform, to develop their community instead of go international. Thank you.
Yeah. The first question was age. There's no problem with age. We don't set an age limit. So you can be as young as 16, you can be as old as 44 years old. And the second question was, pardon? Sustainability. We were established 43 years ago. I have been with the program for 38 years. I'm the most senior faculty in the school now, and I'm ready to retire. I think the most important factors to sustainability are the partnerships that we have started. The partnerships with government, the partnerships with the NGOs as well as the partnerships with the community. That is a very important factor, and they must realize that the need, and we also aligned ourselves with the health needs of the country and with the direction of the Department of Health. So if you have those partnerships and you keep it strong, I think that's the most important factor that has kept us going for 43 years. And of course, as we said, the communities that need health professionals, for as long as they feel the need for health workers in their areas, and they continue to send students to us because they expect them to return and serve in their communities after to improve their health outcomes, the school will survive. Pardon? Oh, about ranking. As we said, we're an innovative program. The equation, our measure of success, is not ranking in the licensure examinations or ranking. We don't rank ourselves, compare ourselves to other schools. What is most important to us is that our graduates have returned to serve and are serving in the communities that sent them. We said the emphasis, we need academic excellence because you cannot send a health worker who is not capable to the community. But beyond that, we emphasize on commitment and service excellence. So we have graduates who are 43 years old. We have medical graduates who have been there for more than 30 years already. Midwives who also have been there for almost 40 years. Yeah.
Unfortunately, we have run out of time. Thank you for all the questions from the audience. If there are any more burning questions, you can find Professor during one of the afternoon or morning coffee breaks. And again, I wanted to thank you for your valuable time and expertise. And we wanted to give you this gift as a token of our appreciation. Thank you so much.